GI problem in which there is a forceful expulsion of the stomach content through the mouth. So it occurs due to certain GI problems like GI infection, GERD, metabolic disorders, motion sickness, food allergies, and obstruction in the intestine, which will lead to the content will not pass through and leads to obstruction in the GI tract and results in forceful expulsion of the GI content back through the mouth, right? Like kind of black backflow. So this leads to dehydration and electrolyte imbalance, and also leads to metabolic alkalosis because all the acids from the stomach is coming out of the body. So it will lead to metabolic alkalosis. So signs will show nausea and abdominal pain, and the signs of aspiration can be there if baby is not able to um, manage that secretions, and abdominal pain and dehydration, weight loss, electrolyte imbalance. So signs of dehydration will be dry mouth, sunken eyes, sunken fontanelles, and decreased urine output. Diagnosis will be done based on the sign and symptoms. Lab tests will be done to rule out the infections, and UTI infections can be assessed by doing urine analysis. Ultrasounds and X-ray will be done to find out any physical abnormalities like pyloric stenosis, interceptions, and GERD, any problem like that. So interventions will be hydration. Oral dehydration therapy will be given, in which we give Pedialyte and the IV solutions in severe cases, antiemetic to prevent the vomiting and if it's a projectile forceful vomiting, it can be because of the stenosis or increased ICP. So monitor for that, and strict intake output should be done. And then abdominal pain can be managed with the pain like things, and treat the underlying infection if it's because of bacteria. Small and frequent feeding will be done. Avoid food triggers. Next, we have diarrhea. Diarrhea is the passage of loose or watery stools at an increased frequency. This is the cause are almost same way. Any GI infection can lead to diarrhea. Food allergies in antibiotic associated diarrhea. Sometimes when you give antibiotic to the baby, it causes diarrhea to them. So malabsorption syndrome like celiac disease or inflammatory bowel disease, Crohn's disease, ulcerative colitis can lead to this. So frequent loose stool, watery stool, abdominal pain, and signs of hydration and metabolic acidosis, because all the bases are coming out of the body. And sometimes there will be cases mucus and blood is present in the stool, right? Diagnosis: we will do the stool analysis to find out the bacteria, like presence of bacteria. Lab test will be done to find out the GI infection, and the imaging can be done to find out the internal cause. The hydration will be done by oral solution. Probiotics can be helpful and treat the underlying cause. Breastfeeding should be done. Avoid sugary and fatty foods, and signs of dehydration should be checked, and Pedialyte should be given. For severe dehydration, we can maintain the patient's NPO status and use IV medications like IV fluids to balance out the thing. The major concern when child is having diarrhea are the risk of dehydration, because it leads to loss of fluids and electrolytes, thus develop metabolic acidosis. So check their vitals very carefully when you do assessment. Next, we have a cleft lip and palate. So cleft lip is a congenital abnormalities that occur due to failure of a fusion of the soft tissues or bony structure during fetal development period, right? So cleft lip, there is a opening. If you can see in the picture, there is a opening in the upper lip or supplet that will extend to the nose, and in palate there is a opening or supplet in the roof of the mouth that involve the hard palate, soft palate, sometime or both. So the huge complication of this is inadequate feeding, because sucking reflux will be not good, and huge risk for aspiration. So causes are usually genetic factor. If mother is taking the smoking, Smoke during the pregnancy, alcohol use, and certain medication can cause this. Or deficiency of nutrients during pregnancy can lead to this. Folic acid is the example. Symptom, you will see the physical defect on their face. Feeding difficulties will be there. Nasal regurgitation of the milk will come back to the like the nose. Speech difficulties will be there, and ear infection because the milk will pass through the mouth and goes to the ear, cause a dysfunction, right? So diagnosis will be done by prenatal ultrasound to find out the cleft lip defect. You can see it on this ultrasound, and a physical examination at birth can help to identify it. So surgeries, it is repaired by the surgery. So for cleft lip, the first repair is done at 3 to 6 months. So first they repair cleft lip, then cleft palate. So cleft lip is repaired usually at 3 to 6 months of age, followed by cleft palate repair, which is performed around 1 years of age. Probably some cases they have only cleft lip, but in some cases they can have both, right? Then palate is done after because it gives them time to normal growth of the thing, and helps in speech development after. Education, post-operative care will include no objects into the mouth such as straw, pacifiers, tongue depressors. Hold the baby in upright position all the time, right? Assess the ability to suck and handle normal secretions, and assess food and calorie intake. No oral sections will be done, and keep the surgical site nice and clean. Small and frequent feedings will be done. Burping should be done often, and small bottles, special nipples, soft nipples are used. And hold the infant in upright position and direct the formula to the side and back, and the slow feeding will be done. Then post-operative care I have discussed already, and the lip protection should be done in case metal appliance or adhesive strips may be taped securely to the cheeks to prevent any trauma. Avoid positioning the infant to the side of the repair because it will lead to rubbing of the surgical site on the mattress, and can bleed out. And then elbow restraints will be can be done to prevent the infant from touching the surgical site again and again. And sippy cups can be used sometime, or special syringes. And in case of cleft palate, they pack the inside area, and which will be removed in 2 to 3 days. So same thing, soft and elbow restraints will be done. Oral section should be avoided, and tongue depressors, straws I mentioned, it should be avoided. Follow up by the speech therapy, hearing measurement, and for psychological support. Complications can be speech delay, dental problems, ear infection. So for all these complications, we will do the follow-ups with each of the specialists. Next we have esophageal atresia. This is another condition, and tracheoesophageal fistula. So in esophageal atresia, what happens, the esophagus will go like constricted at the end. So congenital condition where the esophagus ends in blind pouch and does not connect to the stomach. And what happens in a tracheoesophageal fistula, there is a connection between trachea and esophagus, abnormal connection. So there are a couple types of this. First is isolated, just there is like esophagus is not connected to the stomach, but there is no connection between trachea and esophagus. But then there we have distal tough esophageal atresia. Most common type, upper esophagus ends into blind pouch, and then lower esophagus is connected to the trachea. There is a connection. In proximal, the connection occurs at the upper part. In double tough, the connection occur both upper and lower esophagus, right? So symptoms will include frothy saliva coming out of the mouth, excessive drooling, coughing, choking while taking the feed, unexplained cyanosis because if you are taking something through esophagus and it's going into your airway, it's gonna stop blocking the flow of oxygen, right? So we can go nausea, abdominal distension, and regurgitation and vomiting will be there. So next diagnosis will be done by prenatal ultrasound, and chest x-ray will show the anomaly, right? So surgical repairs will be done. Primary, we have to direct like find the closure of the fistula, and the esophagus will be connected to the stomach. And stage repair, in case primary is not feasible, then we have to place the gastrostomy tube for the feeding, and then followed by a repair. So, and preoperative care will be amniocentesis, prevent for aspiration, do the high elevated continuous intermittent suctioning of the upper pouch, because the like the feed is not going into the stomach. If we are giving it, it's going into the esophagus only, so suctioning will be done, secretions will be going there, IV fluids and hydration will be done. Usually they put GTU so to prevent aspiration, because aspiration pneumonia can occur and leads to distress, and death likely will occur in this case. So if you are not managing it properly, so post-operative care will include managing their vitals, IV fluids will be given, antibiotics, strict intake output will be done, check for chest tube and G tube placement, and make sure it's draining by gravity, and hold the feeds until tolerate the feed, right, is usually attached to the gravity drainage. And oral feedings, before starting the oral feeding we have to do the x-rays first and make sure the connection is built up properly before we start the feed. Before feeding, the gastrostomy tube and secure it above the level of stomach to allow gastric secretion to pass through duodenum and air to escape. Oral feeding will be start with sterile water, and small frequency readings will be done, and we can give pacifiers to NPO clients, but if they are able to handle the secretions, then complications can include GERD, tracheomalacia, weakness of the trachea wall, the respiratory infections if it's keep going into the airway, feeding difficulties, and failure of thrive.